Yes. Okay. And I will, there are few slides. First of all, I would like to ask everybody if there are any questions you can ask, or else what we can do is we can go through some of the important slides. Dr. Meeta को message कर दे कि she can join.
Yeah, but first slow Ali.
अच्छा.
Ali. No, look at this.
Okay. So yeah, so this was a major slide. I think if there is, you can unmute and you can start asking questions. But this was the slide, I think, which had the basic diagnosis and analysis. And if there are any questions on this, we can take that and then move further to other slides. I think there are 4 or 5 slides I would like to discuss on. There was a question by Dr. Devanshi on, Devanshi had asked a question whether that will come in ortho K calculator. There's a point in which we say that ortho K is not data. Yes, Dr. Kalyan.
Yes, Dr.
No, sir, please continue. Sorry.
Okay. So
Actually, I had joined, but then left and now.
Okay. Yes. So this particular slide, so bulk of the work is on this particular slide. If there are any questions on which investigation needs to be done and which need not be done, do let me know, and then we can take it up from there. If there are any questions, we can take on this. See, this is very clear. We can take, this is quite clear. We can take visual acuity. We can do cycloplegic refraction. We can do post-mediatic test. Glasses. This is very, yeah, Devanshi has a question.
Sir, I had a quick question about PMT. Why we would always go for a PMT, and sometimes if we had to any quick tips on how to go ahead without.
So what we do in our clinic is that if you have a patient and you know that so when the patient presents to you, you do the cycloplegic, you do the visual acuity, you have done the autoref. Now you have a fair idea of what his glass power is. You can do a duochrome. You can find out whether this particular patient will accept this number or not. So before you dilate, you can have a fair idea. After you dilate, then you know that this is very close to what you were thinking that patient will have. And since you have a duochrome, it becomes very easy. So
Okay, sir. Thank you.
that is how
We can use duochrome as the main indicator.
Yes. If the patient is cooperative, then duochrome is quite useful. And also, once you know that you are planning to whatever is there in the autoref, normally patient would be accommodating. And once you cycloplug the patient, your readings are going to come at least 0.5, 0.75 less than what the readings are. So normally what happens is that you would keep less power only.
Sir, thank you.
Good evening, sir. Can I ask a question?
Yes, ma'am.
Yeah, this is Dr. Riddhi. So I just wanted to ask, what is the basic infrastructure you should have in the clinic for, starting a myopia clinic? Like optical biometer is a must, but something which suits the pocket as well as the practice. What you recommend is the basic, and what you recommend is should have and, good to have?
So actually, honestly speaking, there is a separate talk on that. But since we are discussing it, we can little bit understand that. Bulk of what we are practicing in myopia at this point of time, normally a cataract surgeon would have most of them, except probably for optical biometer.
Yeah.
So optical biometers also, see if we go into, so if we go more into the slides, I will show you one. This is about the video. Yeah, I had talked about some optical biometers. Now, I'm not being critical about the new myopia biometers, but you see, this particular biometer which we are talking about is around 37 lakhs. Obviously, it doesn't suit anybody's pocket. 37 lakhs for a myopia control clinic is of no use. I mean, also, this one has a technology which is not even swept source. I know the trade people would not be very happy with my thoughts about it. But the fact of the matter is that this is not really, if you have a cataract patient, suppose if you have a cataract OPD and you want to do optical biometry of a patient of cataract patient, this particular biometer will not be very useful for PSC cataracts and grade 3, grade 4 cataracts. So it is not,
Yeah.
basically, it is not a swept source optical biometer. Also, on the top of a simple Lenstar biometer, they have, they have done a tie-up with BHVI. They have given them some, API integration where they have done integration of their software with the software of BHVI. So what we saw in the video, if you saw the video, and we will see that again, the only thing this particular thing will do is this will predict the myopia. That's it. So honestly, you really don't need a fancy biometer like this. Now, this is something. This biometer is purely made for myopia. So people are waking up. People are thinking about making biometers only for myopia. Obviously, you can see that it has a low coherence in interferometry.
Okay.
It is also not swept source, but then they are. This is not right now available. But the owner is a good friend, so he said the cost would be between 12 to 15 lakhs. Again, not very pocket friendly, but it tells you quite a few things, and it also has. If you go into this, it is also a auto refractor. See, it will give you spherical power, cylindrical power. It is the auto refractor with a biometer.
With biometer. Okay.
And it also gives you keratometry. So what it is doing is, it is removing the 3.5 lakhs of ARK, auto refractor and keratometer, and adding more value. So you are putting in the biometer, you are putting around 9 to 10 lakhs and another 3 to 4 lakhs of that. So that is how now they are going back. Achha, this particular device, I have talked with the research guy. He is putting more and more softwares into this, because there's a guy in Singapore by Dr. Marcus Ang. He does a lot of work on AI into myopia. So they are making more and more predictive models of how AI will be useful in predicting not only myopia management, but also in predicting what should be the target, like in target IOP for glaucoma. They are trying to predict what should be the treatment protocol, how much your treatment is actually making a difference, how much myopia is progressing. And in the first instance, this particular patient should be given a myopia treatment or not. Again, I will tell you this particular biometer. Now, I am again very critical because, see, I see it from the myopia point of view. I am not saying that this is not a good biometer. It's a good biometer. But this is not, although the name is MYAH, but this is not specifically for myopia. This is actually a topographer with papillometry, optical biometry, and also it has got infrared dry eye management thing. So midway between, there are a couple of things which it has and couple of things which it doesn't have. So one thing it has, which is good, is that this particular chart it will give you, which is purely for myopia. So what here you are doing is you are putting the data on the same machine. If you check the patient like in 2018, 2014, 2010, it will give you a fine growth curve. Now, if you are even little bit tech savvy, which I know the newer generations are, you can make this from your own Excel sheet. It is not at all difficult. I will make a video and share it with you. And I will also share the Excel sheet also, in which you can put the data and get this thing. It is very easy. You just have to put the X and Y axis, and it will give you a very good this thing. So if you are taking help of a biometer or of a software and paying for it, then it should have something more. Then it should give you more this thing, not just simple growth curves. So that is what, that is why I feel that, still you need more interest in myopia in terms of industry interest. I think this is one device which is giving you complete things of myopia: pupil size, keratometry, cylindrical power, spherical power, axial length, lens thickness, and
does it compare with the normative data too? That too from for Indian children?
which
Does
one?
it have any data?
Which
The
one?
other one that you showed, the graph
one.
that you showed?
Yeah, so this is, I think, so I think what they have is, they have this particular data which is giving the normative data for that age. Very, very tricky, because, you know, even if it is giving normative data for that particular age, it has to be from your data only. See, gradually, once you start doing this, you would realize that it is so much, ethnicity is so much variable. You have to go by your own clinic's data.
Is it for the Indian population, sir?
That I
Indian
don't.
children?
No, I don't
Okay,
know.
okay.
Because I have
Okay.
not. I know that they are giving normative data, but I don't, because it is from TopCon.
Okay, sir.
Hard to believe that this is from Indian data, but could be. They may have got some validation from some major institute. I'm not aware that they have Indian data. I think somebody had taken this machine. I don't remember, but I don't know whether this is Indian data or not.
Okay, sir. Okay, sir.
And I will just show you what I was talking about. Yeah, so this is, I will share this particular file by BHBI, because they have just released their stepwise approach, which is very similar to what has been done in impact guideline and what has been done by others. But the best thing is, there are two websites which are very good. One is this myopia calculator, and another one I had shared in this thing that was predicting myopia onset. So I will share you the link of that also. And this is the video I was talking about. See, this is a simple, very, very simple thing, which is a good thing, but it is going only for 2-3 things. One of them is age, one of them is gender and refractive error, Asian ethnicity, and they don't have they don't have many options here. Now, there was a question by Devanshi on orthokeratology. Orthokeratology, there is insufficient data, not for, there are multiple articles which suggest that orthokeratology is a wonderful tool, but for them to discuss about it, there is not enough data when you do head-to-head comparison and long-term data. So that is why BHVI refrains from commenting on that. But they do have data on high dose atropine. The good thing about this is, see, if you see this particular video, I will just stop it here. Just a minute. Yeah. So this green is with management. This green red is without management. So it's a useful tool, because you can easily tell the patient what you are talking about, and how it is useful. What is the expected myopia progression? And if you give atropine, how much progression will come down? What is the expected refractive error? What is the expected refractive error if you do give this particular management? This is very, very hypothetical, but I'm not saying that you base your treatments on this, but you can definitely use it as a very good tool to convince the patient that myopia is real. This is the progression, and these graphs are definitely there. So that is one part of it. And another part of this particular calculator, I will go back to this point. See, this is they have come up very recently with this. This was not there 1 year back. See, this is, yeah. So this is what we saw. Yeah, they have come up with this, which is a refractive error. Then if you see, you will see that it goes back, and you can actually see axial elongation. This is where it becomes interesting. Now, for myopic children, you can put some axial length. So here it is. I'm sorry, I changed it. So you have to put axial length here, refractive error here, and then they will tell you with management and without management what is the axial length change. And another this is a good thing. The better thing is to predict whether this particular patient would go in for myopia or not. So I think that is a very good tool that can be used by all of us. This is for non-myopic children. What is the risk of myopia? So whenever a patient comes to you, you can show, again, if you see it clearly, you will understand that 2 parents, initial myopia. So what I tried to do was, I tried to find out what is the main factor on which this is working. The main factor is hyperopic reserve. if you see, there are two main considerations here: parental myopia, refractive error, which is the initial refractive error. So whenever you give it to around plus, it will go down to green. So anything more than plus 0.75, this particular calculator will immediately tell you that the risk of myopia is very, very, very low. And the moment you put that initial refractive error on the side of myopic side, like if you put plus 0.5, then it goes into slightly higher. And if you go to 0, it will go into the significantly higher. So your hyperopic reserve is very, very important. This is the most important thing I wanted to tell. The next video will be on pre-myopia, and we will talk a little bit on actually on hyperopic reserve. But this was something which I wanted to bring you to your notice, that this particular calculator can also be used for the same thing. And then there is another website which is known as Predicting Myopia Onset. I will share the link with you, and you can easily see that. Now, I think this particular thing was very clear. Axial length upon CR ratio came very late. By the time these particular guidelines were already published, and most of us were part of this Impact 3 conference from where this was generated. And I think for pre-myopia, hyperopic reserve, parental myopia, and axial length upon CR ratio are the three most important things for pre-myopes. Identifying true axial myopes, right now there is no software which can tell you that this particular patient will progress and this will not progress. So right now you will have to wait and watch for the actual progression to occur. And this all we saw. I think this, not this. I will just show you one particular sheet which I am really fond of. It's a good sheet. Yeah. I think this particular sheet is very good because it sort of summarizes most of the things that we talk about. And the first and foremost thing here is that environmental modifications are the most important intervention that can take place. And then we gradually come to other things like younger age, parental myopia, outdoor time, near time, history of fast progression. Because history of fast progression will tell us whether we should start with combination therapy, whether we should start with only atropine. Because see, regardless of whatever we say, when we start atropine, it suffers from compliance bias. Most of the patients are not able to put it once a day. Sometimes they will put, sometimes they will not put. And I think that is where the glasses will score. So if there is a history of fast progression, normally I would try to go into combination therapy of glasses and atropine both together, or I will start atropine 0.01% twice a day directly. Yes, Dr.
So how do you categorize fast progression, sir?
Anything more than 0.75 diopters per year would be a faster progression. I think there is a good article by Dr. Rohit last month. They came up with atropine 0.05% for fast progressors. We had presented this finding in 2023 at AIOS that atropine 0.05% is a good option. It is not available in the market, and so there are not many many takers for that at this point of time. But it will be available in a couple of months, and then more and more discussions would be when to use 0.05 and when to use 0.01. So honestly, my views on this is that 0.05 is not really having a lot of side effects. We have used it for last 3-4 years. Pre-market trials, even before pre-market trials, we were using it to see how much is the side effects, 0.05%. So if you are using 0.01%, one patient out of 100 would complain that he has a problem in near vision. 0.05, 1 out of 10 will complain. So that is a little bit on the higher side. But the point is that 9 are not complaining, and 0.05 definitely works much better than 0.01. So at this point of time, if you ask me, and if the patient is, if my own kid is there, I would go for 0.05%. And if there are side effects, I will come back to 0.01%. Why would I give 0.01%? When I know that 0.05 is better? If there is a side effect, these are reversible side effects. These are not side effects.
Isn't the rebound higher with a slightly higher concentration?
Yes,
Isn't that?
But rebound will come only after 2.5 years. By that time, see what we saw was that when we were using 0.01%, only increasing 0.01% twice a day was making a difference in almost 34% of the patients. So right now, if I have a patient who's progressing beyond 0.75 diopters per year, I straight away go for 0.01% twice a day. There is no publication on this. Purely it is personal use, and over a period of 5-6 years, we have been using twice a day. And now there are few articles which say that twice a day is useful. Initially, there was some thought process about whether twice a day will be effective or not. But now there are few articles where they have suggested that twice a day is definitely better than once a day. And there are no side effects of twice a day as much as we would think. Acha, twice a day also has, talking about rebound, although rebound is not studied much, but talking about rebound, what we currently do in 0.05% is we tell the patient to stop 0.05 and go to 0.01% twice a day. And then we put them 0.01% once a day. And then only we stop. So it over a period of 4-5 months. And despite that, honestly speaking, if a patient is going for rebound, patient goes for rebound. It's not that doing it slowly, leaving it gradually makes huge difference. But some of the patients, it makes a difference. And so we have made a protocol that whenever you are giving 0.05%, and I'm very fond of 0.05% because at the end of the day, it gives you some sizable difference. 0.01% makes a difference because if there is nothing, you are using 0.01%. I personally think that once 0.05% comes, it would be really difficult for to stop ophthalmologists from prescribing 0.055% as a first line. Nobody is going to reserve. See, even I'm not criticizing general practitioners, but if you see, we always give very strong antibiotics. We can give chloramphenicol, we can give Septran, but nobody gives that. Everybody is giving high-fi antibiotics because we are really fond of doing things more quickly. So 0.05% would become the primary way of treating this. And if patient has side effect, you have got 0.01%, and then it can be used that way.
Sir, whichever person is having that side effect with that 0.05, are you giving a near ad and continuing with 0.05 or stepping down to 0.01%, sir?
That is between you and the patient. If patient wants to continue, then we can tell the patient that you can do it. See, myopia and even pediatric ophthalm, a lot goes into, you have to talk with, see, you have told them so much about myopia, they will be pretty much convinced that doctor, you are the best. So nobody else has told us about myopia. Itna bhi kisi ne nahi bataya. So you ask the patient, see, this has stopped the progression. Now, if it is too much of a bother, if it is too much of a problem, so I honestly have around 30 patients, 30 kids on progressive and 0.05%. In my hands, the best control, Devanshi has worked with us, she knows, best control was with 0.05% and progressive classes. This was before defocus lenses actually came. But we do give progressive. If patient complains, we sit with them, we talk with them that, this is the solution. If you want, this can be done. And, if it is too much of a trouble, we can go back to, or we can start 0.01%. There is no harm in that. But then we do tell the patient that, you can always start defocus lenses along with 0.01%.
Sir, have you come across any cases where rarely one eye will start progressing, the other eye will be the same?
Yeah.
Eventually, 2 months or 3 months later, the other eye will also have
Yes.
reached.
That happens.
So,
That happens.
should we start it on one eye, two eyes together?
You have to
How
start
do we
with
go
both eyes.
about this, sir?
Yeah, you have to start in both eyes together. You can't, see, if you start in one eye, okay, I will tell you one interesting thing. Atom 1, published in 2006 by Singapore National Eye Center. You know what they did was they randomized the eyes. They did not randomize the patients. So what they did was they actually put atropine 1% in one eye and placebo in another.
Okay.
After 1.5, 2 years, they found that they have actually made them anisometropic. Patients were anisometropic at the end of the study. So, this will, they would have just, they would have murdered us with ethical considerations. And so, this is, see, if you are giving atropine and if the effect is so overwhelming, if you remember the classic, the control was 0.2 diopters and 0.77 diopters. That was the difference. So there was almost there was a difference of 0.5 diopters by the end of 1.5 years, and they realized that patients were actually anisometropic. So I don't give one eye. I give them in both the eyes, and I tell them that this is going up. This will follow soon. And some of the patients, yes, they will. There will be some individual patients. We have patients where some of the patients are like that. We give them atropine penalization. They are on 1% atropine in one eye, and they are -6 in right eye, plano in left eye. Actually, we should be giving atropine 1% in the -6 eye. But we are giving atropine 1% because we want to stop their, we want to treat their amblyopia. We are not treating their myopia. So yes, you have to individualize.
Okay. No, the parents keep asking, the lifestyle is changed. The risk factors are almost same. Why this happened? Why that happened? How do we convince the patients? Like, how do we counsel the patients regarding such
I tell
patients?
you, rule number one, always, never think that it is your fault. That is the problem with pediatric ophthalmologists. They care too much about the patient. So you don't have to fall into that trap that it was your mistake. First thing is, whenever they come back to you and saying that the kid is still progressing, you tell them why is he before they ask you, you ask them why is he progressing? What are you doing in the house? You are not taking care. What is wrong with the kid? See, it is very. This is what you learn with age. In initial years of my practice, I used to feel sad. I'm not being able to make a difference. Patient is not improving. Patient is not improving is not my problem. I am a scientific guy. I have done what is needed, and then you get out of that guilt. Don't fall into that trap. You ask them before they ask you. You ask them. The moment file comes to you, you know that this patient has progressed. Patient has cycloplegic refraction has been done. Everything is written in your file. It comes to you, you know he has progressed. The patient comes to you, you ask the mother, patient has progressed. Why is he progressed? What are you doing? What is wrong? Is he doing too much near work? No, no, sir. He is not doing no near work, sir. He's not. Something he's doing. You tell me what he's doing. If you don't ask, they will ask you. See, it is not your fault. You have to understand that it is not our fault. As medical care practitioners, we are doing best. And then you tell them that this is working not as much as you or they wanted to, probably because of their genes, the drops are not working for them. It is not your fault. See, so the classical example which I give them is that if you have got fever of 102 degrees and if you give paracetamol, it will work in some of the patients. It may not work in all the patients. So it is your receptors. So, I mean, it is very easy to understand that everything will not work in everybody. So the problem is that somewhere that particular patient, that thing is not working. So step two is there. You have got step two. You can increase the concentration because it is not working. And you always have to tell that whatever you do, this is the most important thing. They have to do behavioral modifications. Otherwise, it is not possible for you to treat them. If you give atropine, if you give peripheral defocus lenses, and he's sitting 6 hours doing near work, it is not possible. See, you cannot fight nature. You can't fight their hormonal changes. What is going on in the eye. You have to tell that if I am doing something for you, you also have to do reciprocate. This you have to tell them in the first day itself that you are trying to help them. It's not that you are the only person, you are the knight in shining armor, you have come, now everything is gone. No, you don't take that on your head. Don't even take that guilt towards this key. I am treating and my patient is not improving. You never know what they are doing in the house. And never give guarantees that you have given the glasses, now it will not increase. It will still increase if you are doing near work. And if it happens, I will add drops. And if it still happens, I will add orthokeratology. And if it still happens, I may have to tell you to get red light therapy done. We will talk about red light also and experiments which we have done with it. And we will get an expert of ortho and red light when we will have that part. Some work we did with them, and we did our own work, but that is very rudimentary at this point of time. But you can always tell that this is equally important, and most important at the end of the day is behavioral modifications.
Okay, sir. Thank
You're
you,
ready?
sir.
Yes.
Sir, any concentrations in between 0.01 to 0.5? Are they been tried?
Yeah. So the market is suggesting that right now Sun Pharma would come up with 0.02 and 0.05, and Entod will come up with 0.05. So right now, this is what is going on.
But then 0.02 has been tried. I mean,
Yeah,
does
yeah.
it help? Or it
Yes,
it
yes.
must be helping
Okay.
over
So
0.01.
Doctor, 0.02 is, I think when we will talk about atropine, it will again come up, but I will tell you, 0.02, 0.01,
Yeah.
and 0.05, they have been extensively studied in LAMP 1, LAMP 2, and LAMP 3 studies. So there is good body of evidence that 0.02 works better than 0.01, and 0.05 works better than 0.02. And the best among this is 0.05. And the fact that 0.05 works more is because it is indeed a dose-dependent response in myopia progression. So it is known that higher the concentration, better the. So if you see this, I will tell you. Yeah. So if you go back to this, even this BHVI calculator, if you see this, what they have got is, see, low dose atropine 0.02%, the one which we were discussing. And if you pull this drop down, you will see 0.02, 0.05, 0.5 to 1%. And 0.5 to 1%, if I will press 0.5 to 1% also, and you will see that BHVI believes that if you are giving 1%, 0.5 to 1%, the progression will immediately stop. They will show you this. Okay, this is soft keratology point. Okay. See, this is 0.5 to 1%. If you see this, see, with management, if you see this green part, it says that it will not improve. A high dose of atropine 0.5% only progress by 0.06 diopters. The age of the kid is 7 years. The basic refractive error is 0.5. That much is the faith that they have in 1% atropine, purely because of atom 1 study. But high dose of atropine stops the progression. The problem is side effects. So this is
Yeah.
what they are trying to show.
Yeah.
See, percentage reduction is 99%. They are claiming that percentage reduction is 99 with 1% atropine. You can use this BHVI calculator. You just have to log in once with your email password, and you can use it for all the specific data. You can tell your optometrist to do it. You can take a screenshot, take a color printout, put it in patient's paper, and tell them that these are the options which you can use. Or you can keep a laptop and show the patient, see, this is all there. And the other website which I'm going to send you on group is the pre-myopia website. I had sent the screenshots of that, but I'm going to send that website. In that, there is an app also. So you can download the app and also show that how that thing is working. Most of the times, you don't need all this. Uh, as I said, this doesn't really guide you. This just gives you a basic idea. This is mainly for us. This is mainly useful to explain it to the patient what is going on across the world, and these are some fancy charts which you can show that this is what will happen, especially for those parents who are some Google oriented parents who have searched something and you want to tell them more about it. Any other questions?
Okay, so the patients in which who are having say minus point. Yes, sir. May I ask?
Yes, doctor. No, I couldn't get your question. Yes, sir.
Yeah, patients who are having just minus 0.5, and we do a cyclorefraction, and it turns out to be he's accommodating.
Yes.
So then, what about it? I mean, if he's using minus 0.5 glasses being prescribed previously, and then he comes to you, we do a cycloref and find that he's accommodating rather than having a myopia.
Sure.
So do we start classes right away, telling him that this is the cause, or I mean, how do we go about it?
Okay, so you found out that he was actually accommodating. So you ask the patient to come for PMT. You can prove the patient that you can see without your minus 0.5, you can see 6.6. So you don't prescribe him glasses because he is able to see 6.6 without glasses, and they are more than happy because now you have made sure that they are they are without glasses. This part two is that I tell the patient that you are using minus 0.5. In 6 to 8 months, he may progress back to this particular power, and he is right now a pre-myope. So you go back to pre-myopia risk factors, whether he will progress or not. So there are three things that you do. You do his axial length. There is a grading system. मोटा मोटा मैं आपको बताता हूँ grossly his axial length is not very myopic. It is not more than 23.5. His axial length upon corneal radius ratio is not more than 3 or 3.2. And third part is there is no family history of myopia, parental myopia, sibling myopia. So these are mainly the risk factors. And the fourth risk factor is his lifestyle. Like if he's doing too much of near work, too much of indoor, that all we have covered. But you can take that as the fourth risk factors. Most of the softwares, most of the things that talk about grading, classifications, and risk scoring system would dwell onto these 3 or 4 parameters. And you can discuss it with the patient that he doesn't have glasses, but he falls into pre-myopia category, and pre-myopia category is the best category because if you can stop the patient from becoming myope, that is the true service to the society, because now you have stopped one patient from going into myopia. There are two major advantages of that. What you are doing is the future generations, the generational load will not go. That is number one. Number two is that once you become a myope, it is very easy to progress. But the major issue is to stop progression at pre-myopia. So if you can make them understand that, this is very, very important. If you can make them understand that, that would be the main part of all this myopia thing. So if you can stop that and tell them that, you can stop him here itself at emetropia itself, that would be the main thing.
So that was the key concern behind this question, because now suppose he's using glasses minus 0.5 being previously prescribed, and then we find that he is emetrop. But then later on, if he progresses and gets 0.5 actually after cycloplegia, and then parents might even blame he had glasses, you discontinued, now he has now developed glasses since you discontinued. So then if we do all stuff, we will have.
You tell them. Doctor Saab, you tell them at that moment itself that after 6 months he may need it. Right now he doesn't need it. आप संभाल के रखिए. I have three, 4 patients like this in whom I had predicted that this power he was using 3.5. He came to me, it came out to be 2.5. So what I told them was, you take this glass and keep it at a safe place. You will need it after 1 year if you don't listen to me. Right now you can use 2.5. After 1 year, if you don't listen to me, it will become 3.5. It took 3 years to reach that 3.5. But eventually they ended up having that 3.5, and they told me, hey, Abhi Doctor Saab, now it is 3.5. I told them, yes, now it is 3.5 because now from 2.5 you have come to 3.5. If you would have been using 3.5, you would have been on 4.5.
0.5, right. Yes, sir.
You will
Thank
have
you
to
so
talk
much.
initially, sir. Otherwise, and also you can use this. I will show you. This sheet also you can use to convince them that what is happening over a period of time. and he's reading 6/6. That is the best way to convince those people that, you are reading 6/6. And if you are able to read it without glasses, why do you want to use glasses? And here you can see what we are doing is we are taking axial length data, we are taking spherical equivalent, we are taking axial length upon corneal radius ratio. You see, gradually it will keep on increasing. And axial length, you can convert it to the radius, and you can put a formula. You can convert it here, and then you can convert it directly here. If it is possible for you, it is okay. I will send you the small thing. There's a small formula, you can put it. That is not a problem.
So that is a spherical equivalent or only the spherical what you have put there, sir?
This is a spherical equivalent. This is a spherical equivalent. But when we tell the patient, see, that is where the problem is. If you are using a spherical equivalent, at least you should be aware that it is a spherical equivalent and not sphere. Because when the time comes, you can tell the patient that this is spherical equivalent, this is not sphere. So even if there is a change in the corneal power, there will be a change in spherical equivalent. So when we talk with them about myopia, we talk about sphere only. But when we are discussing this, because bulk of the data across the globe is collected like spherical equivalent, we have to take that. That's the only thing.
I think for us, we can write the complete refractive error there with sphere and cylinder just below
Yes,
it.
sir.
It will make it little more long. So what will happen is you will have to write sphere and slash cylinder.
Just in bracket or maybe.
Yeah. But that can be done. You can do that. That is not a problem.
Yeah, thank you, sir.
These are the basic things you can do. I had explained this in the video also. I think you can NPC NPA is a must. Accommodative lag is not really a must. If you want to do, you can do. Pupil size is definitely a must. Binocular examination is definitely a must. Sharma test depends whether the patient is cooperative or not. Serum vitamin D, I honestly don't do it as a routine. I do topography as a routine, aberrometry not as a routine. Choroidal thickness, despite multiple machines, choroidal thickness is not very robust parameters, at least the machines that are currently available here in India. OCT, not in all patients, definitely not in all patients. So there are some mandatory.
So what is the role of accommodative lag, sir?
So basically, when
Right now, because we are not using.
No, there is no definitive role. You can document it just to be sure that accommodative lag is not. So all these 4 things that I have written, you can start atropine without doing that. But once you start atropine, and if there is if patient complains of photophobia, patient complains of problem in near vision, then you will have to do this. So it is better to do it before starting atropine so that you can easily compare it after giving atropine as to if there is anything wrong or not. So accommodative lag, normally the point is that accommodative lag means when you're looking at near, there is some lag. So normally lag would increase by giving atropine. If you give atropine and accommodation is getting relaxed, the lag should actually increase. So that is the reason I say, and we have done good work on accommodative lag and the effect on accommodative lag of atropine, and we have not found any difference. Atropine 0.01% doesn't make any difference in accommodative lag. In fact, we have used atropine 0.01% and 0.05% in pseudophakic patients. And if there is anything to do with accommodation, a pseudophakic patient has already lost his lens. So there is nothing of accommodation really when we talk about such lower concentrations of atropine. And obviously atropine is working or coming out on a separate pathway and not really through accommodation. But if the lag is increasing, once you give atropine 0.05% and the near point of accommodation is receding, it is obvious that it is secondary to atropine because that is the only thing that you have added. So
even 0.05 doesn't affect the accommodative lag, sir?
Very minimal. I will share the data. Devanshi has done work. I will share the data with you. 0.05 also is not making a huge difference. The accommodative lag is not really increasing and not so there is there is a small case series reported from Mumbai by Dr. Mihir Kothari, where they found that post intermittent exosurgery, patient was on atropine, low dose atropine, and the patient developed esophoria, and it stopped after they ceased or they stopped atropine. So that is the only case report in my own uh, experience. I have never seen patients having atropine 0.01% causing esophoria or esotropia. I have never seen that happening in my practice. But yes, there is a case report, and we should obviously be aware that this has happened. So if there is a patient in which you have put atropine and you see that patient has come back with complaints of uncrossed diplopia or esophoria, or you see that accommodative lag has actually increased, near point of accommodation has receded, and his near point of convergence has also receded too much, then you can think that probably it is because of atropine, and you should think of giving an alternate solution to patient.
Sir, to do workup of these patients in the chat which you gave before, just to know, sir, how much are you charging, sir?
No,
Like,
I'm not charging it.
that's like a package.
No, I don't charge anything extra for that. No, but you can charge.
No, this
Not,
Topo, ICL.
I don't charge, honestly. Topo,
Okay. Okay.
we tell the patient that
Uh,
it is chargeable. If patient is ready to give, we charge him.
uh,
Patient says, I'm not interested. Still, we will do the topo. Whether he is paying or not is not the concern. But I'm not at all saying that any one of you should do it free of cost. Not that. See, there are two important equations in my work. I'm into pediatric ophthal, and I have a good practice in pediatric ophthal. So I don't really go into myopia with returns or ROI in myopia. That is number one. Number two is I do a lot of research, and if I don't do topo, I don't get the data. So it is my interest also that I want to get data, and I'm doing my PhD in myopia progression. So I have to get data. At the end of the day, patient may not pay, but still he is paying with his data to me. So that is fine. But yes, I would say that you can. I've never thought about how much should we charge, but if you break it up, the charges will go north of 8,000 or 8,500. So you
no,
can.
sir, because for glaucoma, we have no like glaucoma package where they do CCT or CT
So you
and
can
all the things.
tell the
Like that.
patient that separately the charges would be around 9,000, but because we are taking you in myopia package, we are giving you it in 2,000 rupees. So that can be or 3,000 depending on how much is the prevalent charges. And I'm not saying we should not charge. No, not at all. You should charge. There is no point in doing it free of cost, because everything comes with a cost. All the machines are expensive, and all the machines now gradually what will happen is machines will come oriented towards myopia practice, because regardless of whatever everyone says, more and more people are thinking of myopia as a separate thing. There are more and more patients who are coming up with this particular problem. More and more machines are coming up with names as you can see, this one as myopia master, and there is nothing separate in that. These people as optical biometer for myopia management, optical biometer for myopia. So they have they're coming up specifically for myopia, because they know that there is a separate individual market. Build, manage, and grow your myopia and dry eye practice. So they are separately, name is Maya. So they are separately coming up with myopia. The good thing about this particular instrument is that they have K1, K2 sphere cylinder axis. So they have tried to incorporate autorefractor with myopia. So it comes into one common thing. Obviously, we cannot for the sake of a myopia clinic, we cannot buy another this thing. If we have an optical biometer, that is fine. We don't need to change it. That is the whole purpose of talking about it, that we don't need to buy an optical biometer only for myopia management. But the point is that gradually market is shifting towards pure myopia management tools. Any other questions on slides? Everybody has gone through the video, right?
Sir, can you send a small video of accommodatory lag being tested? We do it, but then we want to just be sure ki it is the right way we are doing.
I will do it. I will do it. I'll just do
Thank
it in one of the patients, definitely.
Thank you, sir.
Pakka, pakka. Any other question?
So for cycloplegic refraction, what do you use, like less than 6 years of age? And like, is it like
So normally I was using homatropin when I was doing my post graduation at Ahmedabad, and then when I went to South, I did my fellowship at
yes,
Mumbai Hospital. We there there's a
yes,
combination which is known as CTC or you use cyclopentolate. It is more common in southern part of the country. Uh, when I came back, I started using cyclopentolate because that is how I had been taught. And so
yes,
there were 5, 6 patients who developed psychosis and reaction to cyclopentolate, and so I went back to homatropin. So at this point of time, we use homatropin. So what I do is I use homatropin at least once when there is a myopic patient, and then I do a retinoscopy in most of them, just to find out if there is any accommodative reserve is there or not. And if there is no accommodative reserve, then we gradually shift towards tropicamide on follow-up examinations. Whenever in doubt, you can always go back to homatropin.
okay, sir. Thank you.
So like CTC, what is your protocol for suppose you're
Same,
doing a homatropin,
same.
like HTC, HTM,
You can instead of cyclopentolate, you can use homatropin. That's it.
and then you, okay, fine. So around 45 minutes to 1 hour you start.
Yes. But all the patients of myopia, you should be very careful that they can be having accommodative reserve. They may be accommodating. You have to be extremely careful that they may be accommodating.
Yes, sir.
So the next video will be on. Are there any other questions? Or any like I have to post a video on accommodative lag, and I will be posting the website name, the pre-myopia predictability, that website name. I will be putting the link in that. Any other questions or anything else? Any other literature or data is needed?
No, so I just want to mention the observation. What I have seen is cyclopental is definitely a dangerous drug sometimes. And second thing is the cycloplegia with homatropin is much better than cyclopin in many of the kids.
I think it is, what happens is over a period of time, it is more like you fall for a particular thing and you know what are it is like using a phaco machine. See, all machines are good. You fall for it. You know what your machine can do, what are the limitations.
So
And
it's a kind of using it.
yeah, but cyclopentolate is slightly more risky. That is what I found. And the problem is that, when you're using it, if something happens to the patient, and it has never happened with homatropin in last 23 years, and if something happens with the cyclopentolate, patient straight away comes to you and says that, why are you putting this drug? And then he will find out some gibberish on the Google that it is a known psychotic drug and it has created havoc with my kid. And then there is no, see, it is not something that we think we are guilty of. But then something has happened, and the patient directly comes to you that, cyclopentolate does cause this, and this is what is happening to my kid. So if you want to know what is to be done in such kids, you have to hydrate them well, and you have to give them some sedative, and that normally works. When they wake up, they are absolutely normal. This was when I had those patients, I had read about it, and so I remember what we did with those patients.
Should
Your voice is breaking.
so sedative anxiety given to the parent also. Just to quieten them.
Yes. Dr. Swarna?
Yes, sir.
Thank you, sir.
So, point, I have a doubt.
Yes.
If I have a child, I have two children. I have one who has a sphere of around -2, and he has an increase of about 0.75. And this after a cycloplegic refraction. Now the other child is around the same age. He has around -7, and he increases to 0.75 after a cycloplegic refraction. So here, do we term both the children as fast progressors, or the one with 2 and 0.75 is considered to be more progressor than something like that?
Maybe both of them are fast progressors. There is no doubt about it. They are progressing very quickly.
We don't take the percentage into account, no, sir. We just take the spherical.
Okay, we take the amount of increase. It is the same. I mean, because I will tell you why. Because if you see the axial length change, it will be same. The amount of axial length progression is by 0.3 millimeters or 0.4 millimeters. So that will remain the same, regardless of whatever is his initial power. Objective value in all this is axial length. So sometimes, okay, what will happen over a period of time, there will be patients in which there is no change in the glass power. Axial length has increased by 0.1 millimeter.
What do you do then, sir?
You just keep quiet. I mean, it's not progressed. What can you do? See, so you don't keep the patient in the dark. You tell the patient 0.1 millimeter has increased, and go back to the original point that you are not guilty of it. You have to ask the patient, see, his power has not increased, but he has increased in axial length. There is a possibility that once you come back after 4 months or 6 months, he may increase in power. So now what happens is you have already predicted that. So
yes, sir.
then they cannot come back to you saying that it is your fault. Now that is handling the patient. Coming back to the scientific part of it, sometimes what happens is that 0.1 millimeter change doesn't really change the patient. See, when you are examining or when you are seeing the patient may not actually be, you will be surprised to see how much is the distance. Sometimes patient will be slightly close and they will be able to see that. So his power may not change. So far, so good. But the scientific explanation is that, if you see it purely in terms of physics, some power will definitely change. We may not be able to quantify it, but then we should be sure that if the axial length has changed, his power will change after 4 to 6 months. So that will also come when we will discuss about, rebound and atropine and peripheral defocus lenses. Yeah.
Thank you, sir.
So
I have a doubt.
Yes, please.
Yeah. So, is it mandatory to check near point of convergence and near point of accommodation for myopia progression, and why?
Near point of accommodation, it's a good exercise to check for near point of accommodation, because not that you cannot start or giving glasses or giving atropine without checking that. The only thing is, if the patient comes back to you saying that he is not able to see for near, you don't know whether earlier also there was a problem or not. See, you have to set a baseline. You have to set a baseline that before you started atropine, his near point of accommodation was 6 centimeters. Then you know that now from 6 centimeters, it has receded. So see, it's a very easy, I think the most simple instrument is RAF ruler. Everything is written on the sides of RAF ruler. and you just have to tell the patient to look at that particular object and see what is the near point of accommodation. Another thing is, when you see all these data points, when you have these data points, no, it is very easy for you to make the patient believe that something, something has been done, and it really helps you. Not that you are doing it just for the sake of doing it. Near point of accommodation tells you whether patient is accommodating a lot or not, number one. Number two, you can easily tell post atropine whether this was because of the atropine or even otherwise he was having a receded near point of accommodation. You have the data with you, so you can tell the patient that this is what we had already checked, and if this has happened, we can stop atropine and it would improve.
Okay. So how frequently should we check near point of accommodation for the patient and NPC?
So what we do is give the patient, we check the near point of accommodation, give atropine. If there are no complaints, so we normally call them after a week or after 15 days, just to be sure that there are no problems because of pupillary dilatation and near point of accommodation. So once they come back, you can check, and then once in 6 months, you can check.
Okay, okay, sir. Yeah, thank you.
So if there are not any further questions, we can close the meeting. I will be posting a video on pre-myopia. That is the next topic. And I have to post a link and I have to post a video on accommodative lag. Okay? Okay, so I will just end the meeting.
Thank you, sir.
Okay,
Thank you, sir.
thank you.